how do we enable safe adoption of AI in health and care? Let me introduce you to our moderator. It's Tariq Khokhar, Head of Data for Science and Health at the Wellcome Institute. Welcome, Tariq. Over to you. Thank you.
Thanks very much, Vernon, and it's a real pleasure to be here. Actually, let me go ahead and introduce straight away Dr. Indra Joshi, who's the director of the NHS AI Lab, and who I have the pleasure of having this fireside chat with for the next half hour. Hi, Indra, how are you?
Yeah, good morning, everyone, and hi, Tariq. Thanks, Vernon. Really excited to be here. Always so awkward in the bedroom, but let's do it.
Yeah, fantastic. So, as Vernon cued us in, we're talking about the safe adoption of AI in healthcare, and the issue of trust and trustworthiness is inevitably going to be part of our discussion. I'm just reflecting on a session that was happening earlier, together with Brimi, your colleague, and Brent from the OII, where they've also been discussing this issue. And it's clear that when it comes to trustworthiness, this is not just a technical question. There's sort of social and institutional aspects to trust to consider. So I wanted to flag that, and I'm conscious this is going to be a far-ranging discussion, but this is not purely technical, right? There's lots of other dimensions to this topic.
Exactly. And NHSX, with the NHS AI Lab, we have a number of sessions as well across the day. So if you're interested in hearing a bit more about some of the work we do tune into those other sessions. And I think some of them will be replayed as they happened yesterday as well. So, Tariq, I've got a few questions I wanted to ask. So before we touch on all of the work that we're doing in the NHS AI Lab and some of the work that you're doing at the Wellcome Trust, what would you say briefly were some of the hurdles and some of the stumbling blocks that innovators and organizations face when they actually adopt or look to adopt AI technologies?
Fantastic question. I'm going to ask you the same thing after I give you an answer, just to give you a warning. This is a fireside chat rather than a kind of direct kind of Q&A. But I think from my point of view, there are two really big hurdles that we need to think about. The first is I think the state of AI in healthcare is still focused on measuring technical performance rather than measuring real-world impact on people's lives. So, what do I mean by that? Every time you hear about, a new app to detect melanoma on skin, the measure you'll get is this is sort of 90% effective, or you get some measure of area under the sort of receiver operating curve. What you're not getting is actual measures of the sort you might get from a clinical trial that tell you what effect does this have on patient outcomes, what effect does it have on people's lives. That's ultimately the standard we use for assessing other interventions in the health system, and we're not quite there yet with AI. The consequence of that is that because we're not requiring that sort of threshold of evidence, the folks developing these systems aren't incentivized to kind of meet that threshold of evidence. So I think it is a challenge for the system as a whole to kind of move how we think about measurement and evaluation, ultimately get that sort of evidence of impact on people's lives rather than purely technical evidence. So I'd say that's one big challenge. The other one I'd say is, and this has of course been kind of in the news of late, is just the substantial public concerns over the use of the types of data that are required to build AI tools that we're going to be talking about. So, whether it's things like the concerns around the GP Data for Planning and Research Program initiative, where there are clearly anxieties about access to commercial data and people's choices, and the sort of lack of communication they perceive can really hinder efforts to generate the kind of broad representative data that you need for sort of trustworthy AI. And I think we just have to recognize we're living in a time where it's not just AI in healthcare, right? It's AI in all aspects of society, and folks are living in a society where often data about them are collected in a way which makes them feel disenfranchised and is involved in the creation of technologies that affect their lives, which they may not feel feel empowered to affect. So I'd say those are the two biggies: that technical performance one, and that just the general notion of living in a world where personal data is being used in a way that people don't necessarily trust. How about yourself? What are the kind of big rocks we need to crack from your perspective?
Yeah, I think, I mean, you talked about evidence and evaluation. I think that's a really critical point. And one of the things we are trying to do with the NHS AI Lab through the award programme is evaluate some of those more clinical technologies that we talk about. But also on the flip side, those operational technologies, ones that might be looking at, say, for example, appointment booking or process automation, is to really see that the impact it's then having on the workforce. So actually once it's in play. And that's really crucial, I think, to make sure that whoever may be the user, be it a patient, a clinician, or a member of the wider workforce, is that they feel they can really trust that technology. And at the end of the day, it's going to seamlessly integrate. And I think that's one of the other key barriers or hurdles we see with innovators, is actually getting that seamless integration. And one of the works we're trying to do with, we have an image program called the NCCID, a National COVID Chest Image Data Program, which is really looking at, on a very small scale, how do we take what we call image recognition technologies, predominantly looking at COVID images, to really then integrate into what we call PAC systems or IT systems that clinicians might use on the front line. And so that is a bit of a challenge that we've seen time and time again. So we are trying to look at those and build the evidence base. And I know Dan and Zhao later are going to talk a little bit more about evaluation, so I won't sort of expand too much on that. But I really think that point you bring along about it's not just about health specific, you know, we're moving much broader now into what we call well-being or general health and wellness that we've really got to look at. And I think you do raise a really interesting point that people do think about, oh, my specific health issue. And actually, you know, in the broader sector of the world and life, we're quite happy to look at all sorts of data that goes back and forth. If we just look at shopping, for example, you know, that's always back and forth.
Yeah, absolutely. And I think just the idea of the data that we consider to be relevant to health, our conception of that is just going to get much wider with time, and that's going to be the kind of thing that organizations like the NHS and the Wellcome Trust, if I'm honest, will just have to contend with. I mean, as a sort of as a science funder, if I walk down the corridor and ask various colleagues what are the sorts of data you work with, typically you're going to have folks thinking about genomic data or data from clinical trials. You know, relatively rarely do we find folks thinking about data, as you say, from financial transactions or you know, geospatial information. It's all just becoming part of the mix now, and it has to be sort of thought about pretty carefully. I just wanted to pick up on the kind of point you made on the more, I guess, operational aspects of data and AI that go on. So, you know, even the example I gave was of like the phone that can detect cancer. And I guess for people who are tuned into this world, they mostly think about that kind of AI and safety of that kind of AI. You know, just give me a sense of what does the sort of the less visible use of data look like within the NHS, and maybe expand on that a little bit.
Yeah, it's so difficult, isn't it, when you talk about AI? And I quite often, so I have 2 young children, quite often try and explain it to them, and they're like, "Mummy, what does this all mean? You know, artificial intelligence." And so sometimes I say to them, it's about looking at patterns, essentially. And we've got a couple of technologies just to really bring it down to the real tangible nitty gritty. So, for example, appointments, we all have appointments when we go into the hospital. And a couple of the technology companies we're working with are looking at predicting what we call non-attendance. So what's the likelihood of you coming to an appointment based on previous appointments that you've been and visited? And so using the data that they have, but also the data from multiple operational sets of appointment booking, to look at to see, okay, is this person likely to attend at this particular day at this particular time or not? And so that's where you look at essentially patterns of data to say, yeah, you know, this is where the AI is working, so to say. And so that's a kind of a quite tangible example. And on the flip side, something we don't always look about, but is, for example, positioning. So some of us have had a scan or we've had an X-ray, and really looking at, you know, is that arm, lung in the right position? and then using what we call computer-assisted technology just to help us position patients or people a little bit into the right position. So when the beams come down or the x-rays come down, they really get the best image. So that's what we call back-end operational things that you don't always think about, but really important when it comes to thinking about, well, lots of large sets of data, how can we find the best position or the best pattern in there? So that's the kind of the thing we see when we're looking at the real back-end processes.
Fantastic. And I should say, I can see a couple of questions coming in, but I want to kind of just extend an invitation to the audience to kind of keep them coming, and we'll come to those at the end, or if anything directly relevant sort of comes up in the conversation, I'll sort of pick them up. Just using your examples there, Indra, going back to the kind of topic of the discussion around AI safety. How do you think about the safety issues in those examples that you gave, both on the kind of operational side and more on the kind of clinical side? So what does NHS do right now to ensure the sort of safety of those systems?
Yeah, I mean, it's a really good question, and we do it in partnership with a number of different bodies. So we are what we call NHSX, so we're a joint unit between NHS England and the Department of Health. But as part of the NHS AI Lab, we partner with the regulators, so bodies I think people are now familiar with, such as MHRA and the CQC. But also on the flip side, we also partner with NICE, our National Institute of Clinical Excellence. And one of the key programs we're looking at is around the regulation. So quite often people wonder, what does regulation really mean? What does it do? And essentially, if you think about it, regulations are there for both safety, but also making sure products and devices do what they said they would do. And that's what we mean by evaluation. And so one of the programs we're doing with the different regulators is really looking about how do we join up some of those services. Quite often as an innovator, you may not know, oh, I need to go to this different regulator, I need to submit this form. And so how do we really join up that service? So we're building something called a multi-agency advice service to really link all the different regulators. And people quite often ask about, well, how do I get access to data, or do I know, have I reached the right ethical levels that are needed? So getting those ethical approvals for data usage in whatever it might be. So if you're doing a trial or if you're building a product, making sure that you're aware of those uses. And so really joining up those services is something we're looking at. And on the flip side, we're also working with Health Education England to really help the workforce as well. So one of the things we're talking about when we talk about safe adoption is how comfortable or how trustworthy do you as the user feel about that particular technology. And all too often we see it, we quite often see, okay, we deploy or we roll out a particular product, be it an app or, an operational system, but we haven't really looked at the more softer side of those skills to use those technologies, and really do the people using them feel that they're comfortable enough to answer any questions that might be asked of them of the particular technology. And on the flip side, that they feel that that technology has gone through a robust enough either evaluation or interrogation, whatever you might want to call it, that they feel that, yes, actually, I think this is something that we can use and feel comfortable using, which inevitably then leads to better adoption, because if it's easy to use, you feel comfortable using it, you're more likely to do that. So I think, there's a few work streams that we have rolled out that we're doing. But again, I think this is much wider, it's much wider than just us in the NHS. I mean, the Wellcome Trust are doing a huge amount of work in this space as well around trustworthiness of technology. So I might flip the question back to you, Tariq, and say, what do you feel are some of the issues that you're doing and grappling with?
Yeah, no, thanks. I think actually I do want to come back to you in a minute on that point around. Actually, there's a question in the chat around what's the importance of things like AI explainability in that setting. So I do want to come back to you on that, but just to give you a couple of examples of what the Wellcome Trust does. So I guess our interest is a little bit broader than just AI safety. We're interested in trustworthiness of sort of data science more generally, but there are some like fundamental ingredients that I think we can contribute. And remember, our interest is international and not just in the UK. So, for example, one thing we'll do is actually fund foundational data sets and tools that allow for these sort of AI methods to be developed. So in the UK, we have a very, as you mentioned, like rich data sets on things like the sort of chest imaging. But for a whole bunch of countries and a whole bunch of diseases, for example, neglected tropical diseases or sort of cancers that are imaged using devices that are prevalent in a particular country, the data sets are just not out there for training or for building kind of robust systems on top of. So we will partner with folks like the Lacuna Fund on sort of funding data sets that help sort of advance those sorts of goals. That's sort of one area. And the second area is really, the Wellcome Trust as an organization. We have a bunch of folks who are also sort of scientists and clinicians by training. So often we will try and act as sort of good citizens in the sort of forums, whether it's things like regulatory discussions or international discussions around standards or governance, where we can really be pushing for the public interest and pushing for a lot of these kind of tools and capabilities to be available, useful, and usable to the widest possible range of beneficiaries, and ultimately making sure that there is equitable access and equitable benefits from these technologies, and that they're not sort of concentrated in the hands of, frankly, just the wealthy or the folks who happen to be in the kind of right place at the right time. So that's broadly kind of how we look at it. But I think central to the issue of trust is looking at trust both through the lens of the public, but also through the lens of professionals, right? So introducing all these systems into the NHS, you have to bring along GPs, doctors, and clinicians as well. So I'd love to just pick up on the question in the chat around things like explainability of systems, and how do you bring clinicians kind of along for the ride, if you like, when you're building and deploying these tools.
Yeah, it's a really good point around explainability. There's a great colleague and friend, Neil Sabir, who gives a really wonderful example around maps. So, for example, we all love using maps, be it Google Maps, Apple Maps, whatever device you have, and to a certain extent, you follow the instructions it gives you, but do you know exactly how it works and why it works? No, but you do trust it because it does a thing for you. And quite often the same thing applies in health, so long as the product, whatever it might be, so take something very simple, we talk about computer vision, so looking at an image. Does that image, is the result it giving me the right thing or the wrong thing? And then the key, quite often, clinicians in particular want to know is, what do I do when it goes wrong? Because that's always the fallacy when something doesn't go quite according to plan. And so one of the things we're working with the regulators, MHRA in particular, around medical devices, is what we're calling AI rigor, or really looking at how do we you can call it validate, explainability. There's lots of different terms for this particular methodology, but essentially saying, when you build a model, how do we know that model is going to do what it said it was doing on a different data set? And so quite often people will get very good results on the training data set they've used or the lab data set they've used. But actually, if you then take that model and put it in a different environment, is it going to do roughly the same thing? And is it going to give the same outputs that you want? And so one of the things we're looking at and building on the back of the image data set is to say, how do we really test some of this? And so slightly nitty-gritty work, and it really goes down to a technical level. But we're not trying to do this in isolation. So on a wider scale, we talked a little bit about international work. So the WHO, in partnership with the ITU, are doing this much more broadly, and they call it benchmarking. And so one of the things we've done is worked with that particular working group to say, look, can we take some of your learnings and can we share back learnings? And I think this really has to be a global effort. We can't in isolation do it here in England or the UK and not actually share it or share those learnings wider, and vice versa. So that's one of the things we're doing around explainability. And on the flip side, I keep going back to the workforce and the trust, but also being able to say very simply what a thing does really helps people understand whether or not they can use it. And so, for example, you know, when you're in pain, people say, oh, I want you to take the pain away. And so you give people a painkiller, whatever that painkiller might be, paracetamol, ibuprofen, but you don't necessarily explain all the ins and out of the pharmacology. You say, you know, it's not going to work on this particular receptor. But what you do say to them is, well, if something goes wrong or the side effects, these are the things you should look out for and come back to us. And so we want to do the same with technology as well. You know, if you're using something to say, well, if it's not quite going according to what you hoped it would do, to be able to recognize that and at the same time have what we call an SOP or an operating procedure behind it. Fairly simple stuff, but important. Say, okay, this is the process that you follow when it doesn't. And so we call that kind of feedback mechanism. And again, working with some of the regulators to really build on those feedback mechanisms.
That's really interesting, Indra. And you sort of answered a question that we were talking about a little bit in the virtual green room, which is, you know, what does all this stuff ultimately look like from the perspective of a patient? So I think that the sort of stylized representation of AI in every magazine I've seen is usually some sort of like Android with a stethoscope. I don't think you're going to be rolling out kind of commander data with a with some sort of medical device anytime soon. But the experience for a patient is going to feel much more like what you described rather than that, which is good. And I think picking up on one of the questions in the chat around the use of personal data and privacy as well. I'm curious to ask you that question as well on how folks should think about how their data are being used and how it's not going to be exposed in a wrong way. Before I answer that question, before you answer that question, though, I want to share just how I think about that, because I think I'm hoping we have a similar view, but maybe we have a different view. So I think this is super important from a trust point of view as well. And of all the kind of nitty-gritty details to go into someone with, this is probably one of those ones to go into nitty-gritty detail to someone with. So I think the model of bringing kind of code to data rather than sending data to code is a sort of good one. So if you can explain how, you know, personal data will always stay within, for example, the NHS or within like a secure environment of a health system, and it's only kind of, you know, pre-approved, trusted sort of code and algorithms that come in, they kind of learn on there, they're audited, and you kind of know what they're doing, and then they're then allowed to be kind of deployed and used. That feels like a model that would inherently be a bit more trustworthy, and something that's worth kind of communicating if we can get to that stage. But I'm curious how you think about those issues of data privacy, and whether that idea of, you know, secure environments, bringing code to data is a direction you're thinking about.
Absolutely. And I think this is, I mean, it's a complex subject, number one, because when people talk about data, automatically the instinct is always to think about personal data, or what we call personally identifiable data. And actually that's very rarely used in the big practice. And so, for example, when I was talking about appointment booking, none of that is identifiable. That is all what we call just process data, you know, A to B, B to C. And quite often, as with all things, without giving a whole kind of overview of information governance, which is quite often key to this. I mean, data privacy is fundamental, isn't it? People always want to know that my data is safe for me. And I think the NHS upholds that. We have something called the NHS Constitution, of which privacy and protection is key within that constitution. And when we talk about building models, I think what you're alluding to is what we are calling trusted research environments, which I think is key and is already in play in a number of different areas. And if I go back to the image data program that we have, the NCCID, it essentially is that. So any identifiable data is removed. And so for people who might think, oh, but you've taken my thing and it's got my name on it or my date of birth, all of that is often removed at source. And so it just becomes what we call an image. So in the olden days, we used to put an X-ray up. Now it's all digital. So it was what we call a digital image. And that is kept. And then people can ask for access to that data or those images build their models, and then see whether or not it works. And so we use what we call trusted research environment. And we're not the only ones who do this. HDR UK, I don't know if colleagues are familiar, Health Data Research UK are big advocates of this. And across a lot of health research we do, I know Genomics England are also looking at these types of environment. And so that's something that's probably, I think, and I hope will be the future that we want to keep going at, because for those of you who know about data storage, it's costly, it's expensive, taking it out of any environment is expensive. Keeping it where it is in a safe, secure environment is always far better. So that's one of the things we do advocate for. And I think as we move forward, looking at how we can more easily, as you say, train models in a different environment is something we're definitely exploring through the image. And I keep going back to images, mostly because at the moment with the AI lab, we've got to cut it down into bite-sized chunks. People talk about AI and health. Health is massive. And so for us to really try and figure out these nitty-gritty issues, if we go down to a very specific area, we can try and solve that specific area and then see how we roll it out, which is why I keep going back to imaging in particular.
Fantastic. I think that's a really good example of the technical dimension of trustworthiness. But as we said at the top of the discussion, there are also these institutional and social dimensions of trust as well. And I'm just scanning the questions here, and there's a good one from Tashi who asks, trust should also come when devices are designed with clinicians and patients. And that speaks to the more sort of social development of like who actually does the development and who's involved. So I'm curious if you agree with that. Should these innovations be developed hand in hand with clinicians and patients? Is that possible? What does that look like? Any thoughts?
I would say it really depends on who you want to use your product at the end of the day. And so people, I'm not at all denying this point. I think but it should be what we call multidisciplinary. So quite often, if you have, this is good process for any technology company or any company really. You have who are your users, who you're designing your product for, and so make sure that those users are involved in the design, but also that it's usable, it's accessible, it's not a difficult technology, and if you have a particular a disability, that you can still use that technology. So it's broadly ranged. And one of the things we've really looked at from an impact assessment is what we call, through the award, we're looking at how will that technology actually impact different communities and making sure that we don't try and broaden any divides or any health inequality divides. Earlier, Tariq, you mentioned, quite often you put technologies in the hands of people who have easily access to them. And that's one of the things we don't want to do. And so absolutely, yes, hand in hand, multidisciplinary approach, multiple different users, but also make sure that technology is really accessible and usable. And I know you, the Wellcome Trust, are also advocating for quite a bit of that work more broadly, aren't you, across the spectrum?
Yeah, exactly. I think one of the awards we made earlier this year was to Regina Basili's group over at MIT, where we're working on just this, the sort of foundations of trustworthy clinical AI, and they're also effectively developing working practices where AI models and tools can be developed hand in hand with clinicians, and often in low and middle income country settings as well, where the context is pretty different, but we still need to do that work to make sure these tools benefit those populations. One other question that's sort of coming up, which I think is a nice continuation of what we're discussing, is just around professionals who are already in the health system who are now seeing AI and these technologies as this emerging force within the health system, who are keen to learn more, who either need to be like formally or informally upskilled or trained. I'm curious, what is your view of that issue, and is there anything that you're thinking about or doing about it?
Yeah, it's a great question, and something I personally feel quite passionate about, because people quite often ask me, how did you get to where you got to? And I don't have an easy answer. It's kind of, I landed on my feet and I applied for the right job at the right time. And I think, quite often, Tariq, be interested in your journey as well. Like, how do you get to where you get to in this health and data science role? And I think for clinicians in particular, what I often say is break the mold. It's so easy to get stuck in that kind of, if you're a doctor, kind of a consultant track or GP track, is to say, actually break that track, go and try something different, be working for a startup or trying to build something yourself, or going and working for a different type of organization, just so you actually understand, when we go back to users, so you actually understand what it's like to work in a different organization. And the other thing, from a real kind of technical and skills perspective, unfortunately right now there isn't, I couldn't point to a particular course and say, yeah, here's your course. A bit like, you know, if you want to do cardiology, there's the training program, off you go, and you'll come out with a specific CPD accredited product or course. But there is a faculty of clinical informatics which is looking at sort of building, not necessarily on AI particularly, but a lot of training programs around informatics, quite a classic word, but technology and digital. Then there's obviously the Digital Academy, which has a module specifically around AI. So the NHS Digital Academy, it's a training course which does give you a specific qualification at the end, specifically aimed at CIOs, CNIOs and CCIOs. And then more broadly, if you look outside the box, and I find this really helpful, a lot of companies have some really good courses just in basic machine learning, coding, etc. So forget about health, but if you're just interested in statistics and want to know, actually, you know, how do I build a basic model, go and do one of these courses. They're around, they're available, and quite often they're free. And without kind of naming any particular company, I would say just have a look out there, really a lot of resources. And then obviously I'd have to put my own plug out there on the NHS AI website. We've put a whole bunch of resources there. So if you are interested, do take a look at the website. I'm not sure if I can I'll put a link in the chat. Hopefully that can be then distributed, but lots of resources out there as well. And really talk to people. I find there's a wealth of knowledge in people's brains. I mean, you know, always talking with you, Tariq, is such a pleasure, because you see a slightly different side. My focus is quite often NHS, but actually health and wellbeing is far wider. So that's probably what I would say from our side. But do you have any resources or bits of information?
Yeah, no. Maybe we should just start carrying around like a list of links to share. Honestly, I think I fully agree with what you said, but I'd also say I think in this day and age, it's worth recognizing that the kind of core of much innovation is basically combining tools from different domains and different disciplines. And often you'll realize, if you have a clear view of a problem, one of the best things you can do to kind of help solve it is to start looking at how other people have solved analogous problems in different domains. Just the way people are trained, you end up getting trained in your own domain. Like an economist gets trained how to be an economist, not how to be like a agricultural scientist or a clinician or something. But I think just being sort of sneaky and stealing ideas from other domains would be my sort of top tip. And I think, as you say, health is one of these areas that intersects with so many other domains. I think it's just ripe for that sort of borrowing from other from other areas. I'm keeping an eye on the clock. We don't have a huge amount of time, but I wanted to pick up on the last question I see in the chat here, which is around a big constraint in low-income communities being access to data and bandwidth. And frankly, that doesn't just apply to folks internationally. Even in the UK, you have folks who live in sort of extremely deprived conditions who are excluded from participating in various aspects of the health system or government in general. So I'd be curious to hear from you, Indra, how you think about the issue of just inclusion and equity within the UK through your work.
Yeah, and I think this is a much broader question, isn't it? So it goes much wider than AI or some of the work we do, particularly in the AI lab. I mean, I talked a little bit about we're calling it the Health Inequalities Impact Assessment. So looking at those technology products in particular, making sure they don't broaden the divide. But I would say much more broadly, NHSX is doing quite a bit of work with a number of communities. We have different missions, and what we do with one of those particular pillars is to really look at how do we make sure that the products that we build, I talked about accessibility, but really saying, looking at communities and saying, well, if you don't particularly have a device, how do you give access to product, what they called iPads, laptops, etc., in community settings, and how do you use the community and build what we're calling a community of digital champions, so that they can go out and really help different hard to reach communities understand that, and also dispel some of those myths. Quite often, I mean, we talk about fake news. There's a lot of myths that need a bit of disbusting. What's the word I'm looking for? Busting, myth busting, which is the difficult thing to say. And a lot of work, what we're trying to do with the digital champions is say, you know, so for example, using an app to book an appointment, it's not going to, you know, it's for your benefit, and trying to help them understand how that's of benefit to them, but also how to do that process in particular. So I would say, you know, it's a broad range of different approaches that we're using, but one of the things to really understand is it's not just about the technology, but we go back to that kind of safe adoption, people's understanding and belief in that particular thing that they're trying to do, and really dispel some of the non-truths, for want of a better word.
Yeah, no, I absolutely agree with that.
Yeah.
And I mean, I think from our point of view, I mean, first, it's just worth acknowledging there are, you know, foundational infrastructure issues that still need to be addressed in much of the world. So talking about data and bandwidth, you know, never mind issues at the individual level, even at the institutional level, there are hospitals and research organizations that don't have good access and connectivity to the internet for accessing and sharing, you know, increasingly large or complicated data sets. So those are just like very bare metal equity issues that need addressing, and it's really the role of governments to kind of address that. But I think one kind of guiding light, certainly from my team, is, you know, acknowledging that the issues that we see around equity in the UK, we can't assume those are the same issues that exist in every other country in the world. And it's just very easy to have that view as someone who's working on this topic. So I think starting from a position of like listening and understanding what are the sort of fundamental issues affecting equity, what are people's views on how health data are used, what are people's views on, you know, AI and the use of these sorts of technologies in decisions that affect people's lives. Those are questions that, just as much as we ask them to folks in the UK, we need to be asking those questions to folks everywhere, because these tools and these technologies are coming. They will be kind of rolled out and affect people's lives, and unless they've had had meaningful kind of engagement with that topic, I don't think in the long term these tools will be ultimately trusted or as successful as they could be.
Absolutely. And I think that the international point is really vital. And I think the last year with the pandemic has really highlighted that. And so I know from a WHO perspective, they do have a number of work streams and a number of programs looking at digital health initiatives and digital health tools, and how these can be more equitably rolled out across low middle income countries. I'm conscious of time, Tariq, so any final thoughts from you, if you had to wrap it up in one sentence?
No pressure. I think my main takeaway here is, one, just reassurance and being impressed by you, Indra, as always, and the NHS for just really thinking about issues ahead of when they become sort of concerns for people. We talked about this a bit earlier, but many of these topics are things that you don't encounter like every day. These are kind of happening behind the scenes, and it's just good to know that you're thinking about them and other folks are thinking about them as well. And I'd say if one takeaway message for folks watching would be, I think there are good places to kind of learn more about these topics and get a sense for them, because I think there's a huge amount of opportunity for people who do want to work on this area to contribute, and to kind of help folks like us who are frankly still relatively early in this journey understand how to do it better and sort of contribute to a better outcome for everyone involved. And then if you have any final thoughts from your side, Indra?
Absolutely. I always say this, we're not, we don't have all the answers. And this is quite often people say, oh, why are you doing some of these things? And I think to myself, we've got to think about what might happen in the future and how do we make what we call an ecosystem or the fundamentals right. If we get the fundamentals right now, whatever gets built in the future in the next 2, 3, 4 years' time will be hopefully safer, more equitable and easier to use. And so that's what we're trying to do. And by all means, if people are interested, get stuck in, get involved. I put the link up there. We've got what we call a virtual community. Hopefully, who knows, in the future we'll have an actual physical space where people can come and visit. But for now, it's there. It's a virtual hub. Do get stuck in. Loads of content on there and information, just if you want to learn a bit more about this stuff or share what you're doing as well and help us learn more on the flip side.
Fabulous. Thanks so much, Indra. It's been a real pleasure as always. I'm going to hand back to Vernon. Over to you.
Tariq, Indra, thank you so much.